And I'm gonna start with a quiz, which is how many people, if you take all the trainees and all the employees and all the full-time faculty and all the voluntary faculty of the Yale Department of Psychiatry, within 100, how many, we'll do round to 100, how many people do you think there are employed by or associated with the Yale Department of Psychiatry? Only primaries, not secondary. You can't answer, you're excluded. So if you actually know the answer, you can't raise your hand. So I only want people who don't know, it's paradoxical, I only want people who don't know the answer to guess. 800? 500?
801.
Yeah, tricky. Yeah.
1,500.
See, 1,100.
1,500.
I know, but there are 1,100. So you're over.
400 more.
Yeah, you're gonna bring them in, and then Well, the reason I did this quiz is because I hadn't really thought about what an important and sizable group we were as a department, and today Vinod Srihari and I are going to be going up to the testify once again to the Appropriations Committee, the Health and Hospitals Subcommittee of the Appropriations Committee, because our dear friend, the governor, has once again proposed to cut the entire funding for the collaboration between Yale and the DEMIS in relation to the research programs at the Connecticut Mental Health Center. If it were to go through, the amount that the governor has proposed to cut is $1.254, as I recall, million, which includes $576,000 that goes to research, to support the research programs, but another $600,000 or $700,000 that goes to programming at CMHC more broadly. At a time when mental illnesses are the most disabling disorders that we have in our society, at a time when more people are dying from addiction every day than ever before in the history of this state, at a time when we have one example after another about how ineffectively treated mental illness and addiction contribute to the serious problems that we have in society, the consequences of addiction, the consequences of unemployment, consequences of homelessness, the consequences of poverty, and even rarely, tragically, the violent consequences of untreated or ineffectively treated mental illness. The idea of cutting this program, which is the Connecticut Mental Health Center, which is a safety net for the greater New Haven area and a mental health resource for the state of Connecticut, it's tragic. It's not, to call it short-sighted, to call it petty, to call it small-minded isn't recognizing the tragedy that would be associated with the cuts. So I wanted to let everybody here know that I will be shortly sending around an email to try to mobilize everybody to write in defense of the programs at the Connecticut Mental Health Center, to write to your representatives, to write the Appropriations Committee, write when I say your representatives, I mean the ones where you live, the people. They should know that people who care about CMHC are distributed all over this region, and that the whole state will suffer if the funding to the Connecticut Mental Health Center suffers. And so we really want to get the word out as much as possible, and the email that I hope to send later today will provide a path to get that word out. You know, I just want to say one thing about this, because this has become like an annual event. You know, today is the first day of the Lunar New Year, and it's, you know, New Year if you're Chinese. And so like New Year's, responding to the proposed cuts to the CMHC budget has become like an annual event. And it would be very easy to feel that discouragement, that once again the governor has proposed basically to kill the spark that makes the Connecticut Mental Health Center a gem. And, but I think we should make it a annual celebration, like the Lunar New Year. That every year the governor tries to knock us down, and every year we ultimately have triumphed. And so I think this year we just need to remember that our letters, our visits to our representatives, our testimony counts. So it'll be very important to get as many people as possible to write on behalf of this mission so that we can celebrate another victory this year, as we have every year since I've been chair of this department. So on that up note, let me introduce Cindy Crusto, who will be introducing our speaker today. Let me just say one thing about today's Grand Rounds before I introduce Cindy, which is we have a lot to learn. We have a lot to learn about how to be inclusive, about how to be truly diverse, what that means, how to, in practice, in the way we think, in the way we do business. And we are on a journey. And today is a step in that journey. It's not the start of the journey, and it's certainly not the end of the journey. It's just one more step in the journey as we learn as a community how to truly respect and include each other and I mean each other, by each other I mean our colleagues, our teachers, our students, our patients, the people that we interact with in our daily lives. To get the most out of our community, we have to be truly inclusive. And so today's Grand Rounds is extremely important as an important continued effort, part of this journey of being truly respectful, inclusive, and diverse as a department. So I really appreciate Darren, our Dean for Diversity, coming to talk to us today. So Cindy, please introduce him for our center.
So good morning, everyone. On behalf of the department's Diversity Committee, I'm very happy to introduce our Grand Round speaker this morning, Dr. Darren Latimore. He is the Deputy Dean for Diversity and Inclusion here in the School of Medicine and our inaugural Chief Diversity Officer. He assumed these roles in January 2017, and I've had the pleasure of working with Darren on multiple programs and initiatives, so I know how busy he has been since January of last year. He earned a BA in microbiology and immunology from the University of California, Berkeley, an MD from the University of California, Davis School of Medicine, and completed residency training in the Department of Internal Medicine at UC Davis Medical Center. Prior to coming to Yale, he was the Associate Dean for Student and Resident Diversity at the University of California, Davis. And here in the School of Medicine, he works closely with the senior leadership team and is responsible for developing and implementing a comprehensive plan for furthering diversity, equity, and inclusion at the school. And this includes robust recruitment, development, and retention programs for faculty, students, and staff. So join me in welcoming Dr. Latimore.
So I want to apologize in advance. If I get this glazed look over my eyes, I'm not about to have a seizure. I'm just a little lightheaded. Before I actually begin my talk, which is going to be about unconscious bias, I actually really want to salute the chair of your department, because many of us in healthcare think that our only role is within the walls in which we work. when it comes to actually protecting our patients. And really honestly, if we really want to change the health of our patients, we have to actually be true advocates and leaders in the community. And one of the ways that we can do that is actually by testifying and making sure our voices are heard in the legislature. Believe it or not, whether it's correct or not, your voices resonate much louder than the patients you represent. So really honestly, consider yourself a voice of the marginalized, the minoritized, and the stigmatized when it comes to truly advocating. So, sir, I salute you. Today, we are going to talk about unconscious bias. I want to be very clear that we're going to be talking about it. For those of you who have heard other talks that I've had, we're not going to be talking about it from a colleague perspective. I do a lot of talks on unconscious bias when it comes to hiring. Today, we're going to be talking about from a patient perspective. How might our bias actually affect the quality of care that we deliver to our patients? All of us in this room at some time have been victims of bias, and unfortunately, every single one of us in this room at some point has been the perpetrator. And I say this to mean that I am not the only expert in the room. So if you have something to add to the conversation, please feel free to raise your hand at any point that I'm talking. Lastly, I actually really would like the ending to be a conversation. Unfortunately, there's a lot of data around the bias, which we'll talk about. There's much less data around what do we do to mitigate it. So hopefully we'll actually have a little time to actually talk about, from your perspective, your department, your patients, what can we do as individuals and what can we do systemically. I wasn't given a slide, so I created one. Psychiatry didn't give me any money. They didn't have a limousine waiting for me across the street to bring me on this side. I have no trips to Europe planned. So I think I can say with unequivocally, there's no conflict of interest. These are the topics that we want to talk about. Today. I want us to slow down a little bit. I want us to actually really sit with the bias that we have. Even though we don't see it or feel it, can our patients perceive it? Okay, it does work. Okay, I like to start with a little fun. This half of the room, I want you to close your eyes and just listen. This half of the room, I actually want you to look and listen to what you're about to hear. When I ask you to open your eyes, you guys say nothing. I'm going to ask this side of the room first what they heard, and then I'll talk to you. Are we ready? So you're going to close your eyes on this side. Okay, go ahead and open your eyes. Those of you, wow, that's bright. Those of you who had your eyes open, what did you hear? Did anybody else hear that or hear something different? You heard Dada. You're right next to her. Did anybody hear anything different than that? La la. I love it. Okay, for those of you who had your eyes closed and only listened, what did you hear? Oh my God. How is that possible? This side of the room completely confused? Yes. This side of the room, very homogeneous in what they heard. Why might that be true?
No visual.
No visual. I often will say, let me put my glasses on so I can hear you. There is realness to that statement. We think we separate what we hear from what we see, and that both are actually factual versus perceptions. The truth of the matter is in this case, for you, what you heard and what you saw were different. Therefore, your brain had a very difficult time reconciling it. Most of the time, your brain will actually listen to what you saw. You heard me? Listen to what you saw versus what you actually truly heard. So again, when we're thinking about our being so certain about what we see or so certain about what we heard, I ask us to slow down and back up. Are we sure? Is that truly what happened, or is that our perception? IOM came out with a report in 2012, amongst many reports. They do one almost every year that actually said very frankly that there is definitely a disparity in the quality of the health care given to people of color versus not, or versus Caucasian. Prior to that, it was all about, oh, those minorities are just poor, oh, they're just uneducated, et cetera, et cetera. This study clearly said when you control for education, economics, and other demographics, the quality of the care that we provide, people of color, is not the same as the quality of care that we provide people who are Caucasian. This was one of the first reports that actually said that out loud and asked us to start taking some ownership. I'm not going to go through these. The only point is it's systemic through all of healthcare. It's not just one area. It's not our friends over there in cardiology, or our friends over there in OBGYN. If one looks at the data, there's probably few areas where actually we can say the quality of care is equal across differences. And unfortunately, because of that, well, actually one reason, there's multiple reasons we have healthcare disparities, but one reason is probably we actually should take a little bit of ownership over. The IOM came out with a report a year later that actually went a little bit further. Even having said that, they minced words so much, I'm not sure the average person understood. But what they were trying to say is, as physicians, we believe or want to believe that we treat all people equally. We don't see color. We don't see economics. We don't see gender. And they couched it, but what they were really trying to say is most likely as clinicians, we actually are impacted by our bias, our stereotypes, and our judgment. And they said, and clinical uncertainty. I actually would have rephrased it for them if I wrote the report. I would have said clinical uncertainty allows us to actually rely on our bias, our stereotype, and our prejudice. Actually, when things are more certain, we are less likely to rely on our bias. It's when things become more subjective that we actually rely on our bias. What does Darren Latimore mean by bias? Let me be very clear. I am not using it in a pejorative way. I'm not using it negatively at all. I am using bias to mean that you are using something from the past, your own past, or a perception of something happened in the past, or the greater society's perception of something that happened in the past, and you are reflecting it onto the moment as if it is factual, whether that's true or not. Now, that's exactly how we all learned medicine. Does it look like a duck? Does it quack like a duck? Does it walk like a duck? It's a duck. Keep on moving. Unfortunately, some of that, how we came to does it look, walk, and quack, is based in science. But unfortunately, a lot of that is based on our own stereotypes, prejudices, and biases. Again, bias within itself is not problematic. What's problematic is when we use it to be prejudiced or to discriminate against patients where some are privileged and some are truly disadvantaged. That's when our bias becomes problematic. It's automatic, it's a shortcut. One cannot analyze every step of the way in the world, so it's quite necessary. Again, becomes problematic when it actually hurts people. Unconscious bias, of which I would assume all of my colleagues in this room, this is the majority of your bias. I hope none of you look at your patient for the day and say, ooh, now which group am I gonna stick it to today? I would assume that that's not the normal. Having said that, we have out of our unconscious biases out of our awareness, not intentional, and if we do not slow the brain down, not in our control. We're gonna do a little fun exercise in a moment to illustrate that. I will say, again, people like ourselves who really, truly want to believe that we treat all folks fairly have the hardest time looking in the mirror. People who are truly bigoted, it is right here, conscious and unconscious. No conflict whatsoever. But for those of us who really truly want to believe we give the highest standard of care to all patients, it's harder for us to look in the mirror and realize maybe not so. Again, the bias itself is not good or bad. It's what we do with it. Now let's have some fun. Bias is fast brain. Something comes in based on your history, out. As if you went to a doctor, they hit you in the knee jerk. No thought process whatsoever. So I'm going to ask you to do this for me. I'm going to show you some colors. This is going to be a demonstration of fast brain, i.e. bias. Just as soon as you see the color, shout out what the color is. I care not what the letters represent. I just want to know the color. Are we ready? Group exercise. Oh, goodness. Pathology specimens are faster. So, I think everyone can agree that you didn't have to think about that. You got input, and you were able to give me output. Well, now I'm asking you to use your slow brain, not to allow your mind to rely on its bias, and actually to give me the answer that I'm actually asking for. Again, I only want colors. I care not what the letters represent. Are we ready? What did people say? What did people say for the first one? No, most people did not. What did people say? If we weren't having fun, if I was not making a point of this, you would have saw red, it would have been a fact, and you would have kept on moving. No question in your mind. Now, again, we're just having fun. But what if this was about a patient and you were going on clearly an assumption based on your past that really truly had nothing to do with the patient in front of you? Then it can actually be problematic. Again, I'm not asking you to do something easy, but I am saying that we do need to slow our brain down when we're actually making decisions about patients to make sure we're basing them on fact and not on biases from the past. One last fun one. What do we see? What do you feel when you see a roller coaster? I'll help you. The right side. So I ask you, where does that come from? Because the only thing in front of you is this. Nothing more, nothing less. But most of us, when we see a roller coaster, multiple emotions come up. Memories come up, and some people even get a little sick. So I won't ask you to say out loud, but when you see this person for the patient for the first time, what do you feel? What do you see? What do you anticipate that doctor's visit or clinical encounter to turn out to be like? Not trying to be a philosopher, but really honestly, the more I do this work, the more I believe this statement to be true. We experience the world as we are based on our past experience versus the way the world truly is. Okay, let's look at a little science. This is vintage, 99. It's one of the first studies that actually looked at this. They actually went to a primary care conference and asked physicians. These are actors. They actually gave them scripts, created videos, and actually showed physicians, primary care physicians, at a conference these videos and asked them which of these patients needed cardiac catheterization. Again, they're all actors. They were given the exact same script. There's really no difference in the presentation. And when you looked at the results, the physicians systematically said white males deserved the catheterization over females, and Caucasians needed it is a better word, over people of color. And the least likely, although the presentation was the same, to be offered catheterization is if you're a black female, i.e. intersectionality. This is one of the first studies to show that physicians systematically offer different treatments to different people, even when the presentation is the same. This study, which was in 2007, was actually, at least they report, the first one to actually connect that to implicit bias, which I'm going to use synonymously with unconscious bias. They, again, created scenarios, and they asked they asked the physician explicitly, do you prefer Caucasians over blacks? And then they had them do an implicit bias test, and then they actually gave them a scenario and asked them if that patient needed thrombolytics. And what they found, as most of these do, is, as I said earlier, our explicit belief of ourselves is we see no differences. In this case, race, ethnicity. Implicitly, though, they showed that most had a preference for white patients over blacks. The stereotypes were that blacks were less cooperative in general, and definitely less cooperative when it came to procedures. And most interesting was that the worse a person's implicit preference for whites was, the more likely you would offer the procedure to a Caucasian person, and the less likely you would offer the same procedure to a black person. And I should have said up front, I know my blacks and whites are capitalized. Those are my politics. It's not misspelling. This was the first connection to the implicit association test. And I know there's a lot of people who have a lot of concerns around the Harvard implicit association test, but I will tell you, it is used most across the nation for this work, and there is direct correlation between the results of that test and outcomes, and behavior, I should say. And something just happened. I just lost the screen. Did I do that? Oh, it came back. There we go. So I'm going to, again, to show that this is actually across multiple disciplines, and not really. We have bias in multiple areas. It is not just about race, although that's the majority of my conversation we're having, but one can look in multiple areas. This study actually looked at people who had gone into the Harvard Implicit Association website and taken the test around weight. Then pulled out those who identified as a physician, which gave you the 2,282, to see if there was any differences between physicians as a cohort versus the general population's bias against weight. There was not. We had significant bias against weight. Men had a stronger bias than women, and that's in general. Women tend to have less bias in multiple areas, not just weight. And our perception of how thin we were or full-figured had a direct impact on how biased we were against people who were overweight. 70% or so of the people felt that they were of normal BMI. I'm not sure if that was reality or perception. Another study looking at gender. This one was done actually in Canada. There's many studies around gender and heart disease, but this one I pulled out because it's something different. Primary care doctors, and it looked at the ortho doctors also. Created scenarios, x-rays, mild arthritis, moderate arthritis, severe degenerative arthritis. Male versus female, should they actually get a knee replacement? Bottom line. And what they found, if it was mild arthritis, everyone said no for the most part. If it was severe, no matter what the gender was, pretty much not. If it was moderate, again, that uncertainty, the primary care physician was significantly more likely to refer a male patient to the ortho doctor than they were a female patient. A lot of people will say, well, the female patients, they don't want to have knee surgery. They're afraid of it. They're the problem. Well, the truth of the matter was in this study was that the physicians didn't even offer it to their female patients at the same rate of which they offered it to their male patients. And once they got to the orthopod, the ortho doctor agreed less often that they should do anything with a female patient than they did a male patient. Again, as healthcare providers, we need to take some ownership over this disparity. Yes?
In that study, did it make a difference if the physician was male or female?
Actually, I don't remember exactly in this one, but I can tell you in general, just like in the previous one, African Americans had bias against black patients too, not to the same degree. And usually the gender ones, women will have bias also, but not to the same degree. I don't remember specifically in this study though. Oh, actually, we're gonna skip. This is where I want to slow down. I think we've actually come to the conclusion that we actually have bias. I think the next question now is, can the patient perceive it? And does it have an impact actually on the outcome of our interactions with our patients? And that's the conversation I want to have for the next two studies. So this study looked at 3 health systems in the Colorado area, and it was nested in another study. They had them do implicit association tests, and the Black implicit association test and the Latino versus Caucasian, and then they had them do explicit surveys, and these are the ones that they used. On the patient side, again, the patients were nestled in another study, a hypertension study, and they did a primary care assessment survey. At a minimum, they had to have been seeing the same primary care doctor for over, I think it was 2 or 3 years, and they had to have seen them a minimum of a certain time. The average was 7 times. So most of these patients and doctors knew each other. Again, the patient's perception on their treatment, on communication, do they trust their doctor? Do they feel that their doctor actually conveys knowledge to them? Explicit, what the doctor said as far as their biases were concerned, had absolutely no correlation with the patient's perception of the doctor. However, if you looked at the implicit studies, this is higher than average. I want to be very honest with you, but this is the results of their study. That some level of bias against Blacks and Latinos, 66% of the physicians had. Again, that's higher than normal, as is the moderate to strong. 43% had a moderate to strong if they're against Blacks, and 51% had a moderate to strong against Latinos. Again, higher than the average study. I'm not sure why. But what was interesting is the stronger the actual implicit bias of the physician, the lower the patient rated their interactions with that physician. And I will show you the graphs in all 4 subdomains, and it's statistically significant. And I'll show you the graph in a moment. That was for African Americans. That was not for Latinos. Now, and it doesn't really explain well enough in the study for me to know if there's confounders, if they actually looked at accent versus not, if they looked at Latinos who are more European looking versus more indigenous. So there may be some confounders as to why there's no obvious correlation here. But if you look at African Americans, there is no question about the correlation. This is strong preference for Caucasians. On this side, this is patient's attitude towards, or belief the physician's attitude towards the patient. Very direct correlation in every area. So, what I ask you is when you have that patient of color whom is non-compliant. Which came first, the non-compliance or your bias? When you have that patient who just does not show up, which came first? Their dinkas or your bias? I really honestly think it's a question that we need to start asking ourselves. This study also is looking at, and it's a small study, there's only 40 physicians involved, but they actually looked at the Harvard Normal Implicit Association test, and they created one about stereotypes about our beliefs of compliance when it comes to medication adherence. The good thing, or what they did differently, is they actually audio taped and videotaped the interactions so that they actually could have independent people look at markers or measures, and then they got patients' perceptions. And what they found was that race bias against African Americans, if you look at all clinicians, and this is about a moderate, that number. If you looked at just the Caucasian physicians, again, moderate. If you looked at the African Americans, actually, it was still some bias. It just happened to be very slightly in the African American direction. Now, what I want to say, and they don't say it actually in this study, is African Americans really on an individual level, bias varies. There are many African Americans who actually have bias against African Americans. They grew up in the exact same society milieu as the rest of us. There are some African Americans who actually have bias against Caucasians. So you get a lot more scatter in the bias when it comes to African Americans, but bias is still bias. When you look at Caucasians, especially men, it is very much in one direction, and that is bias to preference for whites. If you look actually at the compliance scale, you see something similar, although the Caucasians have even a stronger bias against African Americans. How does that translate in actually the audio and videotapes, and how does that translate in the patient's perceptions? If the clinician had a preference for whites, it led to more verbal dominance, i.e., physician doing all the talking and not listening to the patient. If you were a Caucasian physician, it was even worse than if you were a black physician, but black physicians did the same thing, just to a less degree. The patients, when you actually listened to their voices and looked at them, their affect actually was lower or worse. Again, the physician probably has no clue what they're actually transmitting. Patient has less respect for the clinician, less confidence in the clinician. If I have no confidence in you, why should I swallow your pill? Less likely to refer you to other people, friends and family, which I think probably correlates less likely to come back and see you again. If you look just at the stereotyping one, very interesting. If you thought that, if you had a stereotype that African Americans are less compliant, the visits actually were longer in this study. Most studies actually, when there's congruence and bias, the visits are shorter. So this is actually unusual. Having said that, in this study, it did not add value because they were longer because the physicians act as if the patients were morons and talk to them slowly so that they would understand what was being said to them. The conversations were less patient-centered and more about trying to beat into the patient. You need to be compliant. You got to take this medication, instead of trying to get a better understanding as to maybe the whys, as to what might be going on in their lives to prevent them from being able to do whatever. Again, the black patients had lower trust, and the black patients had less confidence. So again, before I move on, and actually I have a lot of time, these two studies actually really beg a question. And that is, when our interactions with our patients are not going so well, how do we actually look at that? Do we continue to write all over the chart, non-compliant patient? Or do we actually start thinking about coming up with tools and strategies to figure out, what am I, as the provider, contributing to this? I hope we can move towards the latter. Some ways to mitigate. Well, the data around bias in general says that the most important thing is to actually have the conversation, which we are doing now. The more often that you actually can bring this into the milieu, the better. What I want to say, though, about this is it has to be done correctly. A lot of people like myself think that we can just beat it into somebody's head. You're biased, with a hammer, and that somehow is going to change behavior. The studies actually show if it is not delivered in a way that the person can receive the message, you actually can do more harm. You actually can reinforce the biases. So again, if you are the messenger or trying to facilitate this conversation, be very aware of your audience and aware of how they can actually receive the conversation and participate. As clinicians, I am asking you to actually put a flashlight on yourself. We've put a flashlight on our patients long enough. It's time to look at ourselves. If you've never done any of the Harvard Implicit Association tests, I would encourage you to. Again, like I said earlier, there are many people who who are good scientists, who have some issues with it, but at the same time, this is what's used most often. And I would encourage you to do as many of them as possible. Most of our conversation, again, today was around race, but we have biases around many things. And until you do some self-reflection, you will have no idea which ones you should own. I'm sure I left off a few. At a more systemic level versus an individual level, I really would advocate that we do a better job of actually trying to understand differences in patient outcomes and even ask the question about differences in satisfaction of patients based on identities. And actually using that information to see if there actually may be either systemic bias in our process or we as an individual. It's not necessarily, in my opinion, the motivation might not necessarily be the best, but some of the actual best ways to actually mitigate this is actually to measure it. So in my world, where I came from before, I would actually get periodically what percentage of my patients' blood pressure was under control, what percentage were on beta blockers, what percentage were on aspirins, based on race, ethnicity, and gender. And I could see how I was doing compared to my colleagues in my practice. It was a very interesting way to help me see what I was doing different and what I was doing different for certain patients. Like I said, many of the studies actually with discordant physician and patients, where they actually show some bias, the physicians trying to get out the room as fast as possible. And it's statistically significant that the visits are usually shorter. So what I say to you as providers, if you feel awkward in the room, if you feel discomfort in the room, that is the time to lean in, not to find a way to get out. Again, you have to start reflecting within as to what it's coming from, what's causing the discomfort. But again, please don't use discomfort as an excuse to leave, which is what we do most often. as some of you have heard me say, actually really emerging yourself with people who are different than you, which can be based on many things, is probably one of the best ways to actually mitigate bias long term. However, for that to be successful, it really needs to be done with humility and needs to be done as if you are actually the learner, which unfortunately in healthcare, we often think of ourselves up here. If you approach this as I am here to save you down there, at best you're probably going to reinforce your bias, and at worst you're going to reinforce someone else's stigma. But if you come to a situation with humility and actually ask questions, I think you can learn a lot. I'm going to use myself as an example here. When I was a resident, actually right out of residency, I started doing transgender care, of which I had not had a transgender patient ever before. No one in my family, at least that I knew of, was transgender. And I was, I was down for the cause. I really, really wanted to develop a practice. But I realized I was messing up my pronouns left and right. It wasn't because I didn't necessarily respect my patients, but I really realized very quickly I had a strong bias in my mind of what a man looked like, and therefore the pronoun that went with it, and what a woman looked like, and the pronoun that went with it. It took some humility. It wasn't. And I started off like making excuses. I started off by not even acknowledging I had called someone by the wrong pronoun. To really, really, really get past what I actually was experiencing and bringing to the table, I really had to own it. I really had to be humble and say, okay, Darren, this is how your brain is working, which is not productive in this situation. Let's work on that. We all can do it. It starts with actually talking to one another. Feedback. Especially as physicians, other clinicians in the room may have a different attitude, but we're not really good about asking for feedback. But really honestly, if you're having issues with certain patients, even at the individual level, but definitely at the population level, ask your colleagues, ask the nurses what they're observing. Ask people around who actually see your interactions with the individuals. What are you contributing to this? What could you actually change? I'm going to end here. Hopefully we can turn the lights up so I can actually see you in the back and have a real conversation. I do want to end with, not only do we need to acknowledge our biases, I think many of us have gotten that far. We need to acknowledge that our biases are really having a negative impact on our patient interactions. And clearly, based on these last couple of studies, our patients actually perceive our biases way better than we do. So we really need to get to work at figuring out how to mitigate them. Thank you so much for the time. Can we turn the lights up? Is it possible to turn the lights up? Questions, comments, additions to the conversation? Oh, yes.
Thanks so much. It's a really great presentation, and your energy is much appreciated.
Even when I'm sick?
Even when you're sick. Has there been any pediatric studies on this with pediatricians looking at different races of people?
Unfortunately, yes, around pain. It had been documented very well, actually, in the adult literature that if you're an African American, you're less likely to get pain medicines. They've actually also documented in the pediatric population less likely to give pediatric patients pain medications. Even when they come in with an x-ray that shows a broken bone, we are less likely to. Because we have our society, again, has stereotypes around who's drug seeking and not. So yes, that's the one that I know most about, is around pain.
Thank you again for your talk. I appreciate you opening up this conversation for our department. I've been struggling with a few ideas and concepts throughout the development of your talk, and one was something that you started out with in the beginning, talking about how clinical uncertainty plays a role bias being inserted.
Resorting back to your biases,
Right, being
basically.
inserted into our clinical care. And it made me think a lot about the nuance of what goes on in the mental health care field and in psychiatric care. And that we are dealing with very nuanced disorders that are not often as clean cut. I mean, we have our DSM criteria, but so often because we're dealing with people and we are complex and our criteria are not necessarily reflecting what the science, what we know about the science of psychiatric disorders, then we are in a very nuanced and complicated field that can lend itself to clinical uncertainty in a way that other fields might not. In addition to
Actually, before you move too much further than that, I'm not going to disagree because I'm not in your field, but I am going to say, even before we get to the treatment, even at the diagnosis stage, there is clear data that shows that certain groups of people, race, ethnicity, and genders are misdiagnosed. So before you even get to the nuance, I mean, unless you're telling me that your DSM book does not tell you how to diagnose, so we so we need to step back. We're not even at the nuance yet. So part two.
is related to the fact that, as you said, we are not people. We don't feel like we are biased. It's certainly not something that is conscious and not something that we want to. It's something that we are concerned about enacting, but for better or worse, oftentimes for worse, it is still enacted in our clinical practice. And part of that, sorry, I know it's the long-winded sort of thing. Part of our training is sitting with that discomfort and even asking questions about, is there something about me that makes you uncomfortable, or is there something about what thoughts you may have of me, or thoughts you may think I have of you that make this interaction uncomfortable. And I think, at least in the residency program, we're encouraged to ask that in certain clinical situations. But I'm wondering if, because we do that, we think we've done enough. And there actually may be more behind that. And even though we are, in some ways, more aware, or at least prone to ask those questions in some situations, there is still a lot of nuance, and we are still complicated individuals, and we do still bring our bias into the room. And I know this may not be something necessarily that you might speak to in general, but I just want to open that up to
the
the
group.
community.
So I think it's a wonderful question. And the studies don't ask the patients, was your doctor biased? The studies are getting at a sense/perception that the patients have, and they may not know where it's coming from, but they know they're leaving with a bitter taste. So I don't know if the way you ask the question, and I don't know how you ask it, so I'm being very clear, being honest when I say I don't know, if it actually would get at this. And I don't even know if the right people are asking the question. So that I would definitely say. Number two, the other thing, not to give us a pass, but to also say clinical medicine has gotten much more stressful and time crunched. And the less time that you actually have to think, which is really what you need to do to not rely on your biases, the less time you have to think, the more likely you're going to jump to your biases because you got to keep moving. So structurally, we have changed medicine in a way with shorter and shorter visits to actually make us rely even more on bias than not. So there may be a couple structural issues that we need to grapple with, some of which we have control over. Others, unfortunately, have a lot to do with financial reimbursement, and we have less control over unless we start to do some advocacy. I thought it was someone else, but I'll come to you, and whoever else, please raise your hand again. I don't remember who it was, so go ahead.
Okay. Thank you for a nice talk. You talked a lot about, maybe exclusively about, the bad outcomes that come from acting on biases. Mm-hmm. But I would say maybe as physicians, we are, you said, rates of biases are similar to the general population. I wonder if there might not be some reasons for them to be higher. The reason I say that is we both select for and train people in the art of pattern recognition. So most of what we do in diagnosing is not to check off what's in DSM or any other checklist. It's to say, this looks like pneumonia. This feels like a key E because it matches what I've seen with other patients who have that diagnosis. This looks like bipolar, this looks like borderline, and they feel different. And so a lot of what we're doing is both selecting a cadre of people who are good at forming unconscious impressions and then training them to create those patterns. And that's very useful.
So like I said early, I think I said it 3 times, bias is not inherently good or bad. I was very clear about that. It is not. It's what you do with it. And I agree with you. When I said we're trained to see a duck, it walks like a duck, quacks like a duck, which is exactly what you just said. But that is science. What we don't also realize is we are saying, ooh, a black man just walked in. And whatever associations we have with that, not so much based in science. Or a woman just walked in, and whatever associations are associated with that, as if sex and gender are the same thing. Again, not so much based in science. So I agree with you. First and most importantly, bias is not inherently good or bad. The problem is when we actually use it to disadvantage some people and advantage others. That part tends not to be the part based in science. Yes?
I've often wondered how much we're biased, whether in a positive or negative way, by reading a patient's chart before we meet a patient. And it certainly depends on whether, quote, the patient's a good historian or not, but I don't know if there's been any studies to look at outcomes based off, quote, like a blind
First visit.
with a patient versus, categorizing all of the other opinions and physicians that the patient has seen before.
I've not seen a study, but I think it will be fascinating to see how the patient feels about the visit after they leave when you've read a chart about non-compliant, drug-seeking, antisocial, blah, 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 versus a truly new patient of which you know nothing about. I think that actually would be fascinating. What is it that you actually transmit to that patient? Especially if they come in with the exact same complaint, which may be completely valid. I think that actually be very, I will say personally, there is no question that chart lore actually creates an impression. No question, positive or negative. And unfortunately, half of chart lore is just that, chart lore, and inaccurate. Actually, the person behind you, I think, first. Did you have your hand up, sir? No, you did? Okay. I thought the person behind you. Go on.
Okay. Just the comment on in many areas of medicine, the bias may show up as under medicating someone if they are reporting pain or not doing the knee replacement or whatever it is. But in psychiatry, if we're talking about schizophrenia, bipolar disorder, major depression, particularly major mental illnesses, the bias may show up as over-medicated compared with white cohort. And this health disparity is important to think about and recognize in the work.
So can I actually address your first part on the medical side before we get to the psychological side? Actually, there are studies that actually, if you look at Caucasian populations, it actually is overdoing 2 procedures. So depending on who the person is, if it's a more affluent Caucasian male, we are much more likely to do a procedure that is inappropriate because of our biases around those individuals, especially people whom we think are affluent or somehow of high stature. So actually in medicine, depending on the group, my conversation is all about the minority, the minoritized, the marginalized. But if you look at the privileged, that bias actually leads to overutilization too. Yes, back there.
Thank you for this really eye-opening presentation.
Hold on one second, I'm sorry, because I'm going to either break this or trip. Okay.
I have a question more about like what, because this is like a great presentation, and I'm sure that like nursing and staff, like all of us need to be thinking about this, right? So are there systems in place like where like here at Yale to train people like to recognize their unconscious bias more? You know, like are there any systems in place about this? What's happening here basically?
So I will say that I will say that there's no system. There's many individuals, including myself, that are trying to bring awareness. But have we really truly systematized it? That no, by no means at all. But there's many, many things here at Yale that we probably could take a systematic approach to that would be beneficial, not just this. Yes, sir.
I was curious if you had any thoughts about the distinction between biases that manifest themselves from more physical characterizations or things such as age, gender, and race in comparison to things that are more concealable in terms of identity, like sexual orientation, things that might not necessarily come up within the first few visits and might develop over time if that provides a different source of bias or different manifestation of that.
Actually, I've not seen data on that. But having said that, I think it's all complicated because even if you look at race, one of my issues with the Harvard Implicit Association test is that we act as if race, skin tone, and features are separate, and they're not. As an African American man, if I have more Caucasian European features and very light skin, I am definitely treated different in the society as an African American man who is much darker and has much more African indigenous features, as is the Latino community. And I would say as a gay man, if I was much more butch acting, I probably would be treated differently than I am as I am. So I think even what you consider outward really varies from person to person. Having said that, it'd be interesting, is I think what your real question is if you get to know somebody before you actually learn about their differences, is it different? And I don't know if that's been studied or not. I think it's a very good question. It sounds like we got some research projects in the room. Yes.
I'm a second-year resident in the Department of Psychiatry, and one of the things that I want to bring up is the interaction with other colleagues and what they expect from me. I'm a Latino male, and for example, the expectation that I should know how to treat Latinos comes up often, and it often leads to very, unnecessary assumptions, and it affects my own patient care. And at the same time, I don't know if I'm the best actually to provide that care. So that is another pathway where, like, my colleagues assume that I know, all of the cultures of Latin America, and therefore I have to ask about curing schizophrenia when I'm not an expert. I'm a trainee. And so I don't know if that happens, I definitely know that it happens to my African American colleagues. I don't know if that happens or if that has an interaction with gender or other socioeconomic demographics, maybe explicitly, and because this comes as an explicit sometimes advice from or request from my attending or my supervisor, and then it sometimes translates into implicit bias.
And the other, so thank you very much. I 100% agree with you. And the other part to that is we make the assumption that the patient, who is from whatever minority group or marginalized group, actually wants a provider of that same identity. And that's not necessarily true. It often may be, but not necessarily. And so you actually may be compounding or creating a new issue by thinking you're doing quote unquote the right thing. Yes.
So I really appreciate the presentation. I've learned a lot about biases in the clinical setting. I work as a research assistant, and I'm wondering if there are studies that look at the differences in how research participants, minority research participants, and the biases that occur, PIs and RAs.
Actually, I'm not as expert on that, but there definitely is a body of literature around that. Even in who gets asked to be part of a research, how it is framed to them. Do you do a proper, true consent? Varies drastically on your biases as to how intelligent you think a group of people are or are not. So yes, I'm not as expert, so I can't quote it, but yes, it does exist. Yes.
So thank you for a wonderful presentation. Just getting back to the question about what sort of systems are in place for reducing unconscious bias, what recommendations would you have that could be implemented in our department and others? I know that's a broad question, and this is one of your main jobs.
So first and most importantly, I think almost nothing happens if you don't measure it and if there's no accountability. So whatever system we come up with, and I'm not going to say the specific because I don't know your area well enough, there needs to be a way to measure. And there needs to be, at the end of the day, either a carrot or a stick to say you are doing the right thing or not doing the right thing. I do believe that what the information that we get from our patients, at least when I tried to get patient data here, by differences, I was told it did not exist. That we don't even ask those kind of questions. So how on earth are we to look and see if our patient either outcomes and or satisfactions vary based on differences? So that would be the first place to start, in all honesty. Now, if you do see differences, it may or may not be biased. There's multiple reasons as to why you may see difference in outcomes and difference in satisfaction, but that will be a place to start. And then to start measuring it. We can have the conversation, but if there is no real impetus to say, if you do not change, then you may not be appropriate for the Yale culture. And until we're willing to actually say that on behalf of our patients, nothing's going to change. A measurement and accountability. But we got to come up with a measurement that actually makes sense and is measuring the right thing. Getting back to your point, I'm not sure you having the conversation with the patient about countertransference is actually going to get you the real answer. Yes, sir.
Continuing the conversation about steps to take or things to do, you know that one of the things, for example, that works for decreasing stigma and discrimination against people with mental illness in general is social contact. The more social contact you have, the less you're biased against people with mental illness. I'm wondering if that principle of social contact applies in this context.
Absolutely. That's what I meant by actually engaging the other. That's what I meant by that. But again, if it's not done correctly, if it's done that missionary style where you're going to save those mental illness people, then that actually does not help your bias one little bit. So it has to be done correctly. But I do agree with you. But it actually can be hurtful if not done correctly.
Are there examples of where it has been done correctly or incorrectly so we can learn from that?
A lot of our going around the world is the incorrect part. But I'm sorry, that didn't come out right. I apologize. Let me actually, so I don't misquote literature, can you send me an email and I'll make sure I send you actually something? I think I probably should be quiet now, huh? Thank you so much for coming.